Bismillahirrahmanirrahim. Quote of the day. And verily, whosoever shows patience and forgives, that would truly be from the things recommended by Allah, Al Quran. Assalamu alaikum, everyone. My name is Dr. Marina Akhtar, PGR Community Medicine. Today, my topic of presentation is malnutrition. I am presenting this topic under the kind supervision of my professor, Dr. Saira Afzal. Learning outlines. Malnutrition, its definition and forms, concepts of food gap, web of the causation of the malnutrition, level of prevention and mode of intervention, growth monitoring and nutritional surveillance, and recent updates and the MCQs in the end. Learning outcomes. At the end of this presentation, the participants will be able to describe malnutrition, its forms, concept of the food gap, management protocol of an individual with malnutrition, recommended strategies for its prevention, the differences between both growth monitoring and nutritional surveillance, and the global recent advances in the context of malnutrition. Malnutrition. A pathological state resulting from a relative or absolute deficiency or excess of one or more essential nutrients. It comprises of four forms: undernutrition, overnutrition, imbalance, and specific deficiency. Undernutrition, a condition which results when insufficient food is eaten over an extended period of time. In extreme cases, it is called starvation. It is not only an important cause of the childhood morbidity and mortality, but also leads to the permanent impairment of physical and possibly of mental growth for those who survive. Undernutrition, the term encompasses three frequently encountered problems: wasting, acute malnutrition, stunting, chronic malnutrition, and underweight. Overnutrition, a pathological state resulting from the consumption of excessive quantity of food over an extended period of time. The high incidence of obesity, atheroma, and diabetes is attributed to overnutrition. Imbalance, a pathological state resulting from a disproportion among the essential nutrients or with or without the absolute deficiency of any nutrients. Specific deficiency, a pathological state resulting from a relative or absolute lack of an individual's nutrient. Undernutrition of vitamins and minerals. Undernutrition of minerals include undernutrition of calcium that causes rickets, and the iodine deficiency causes goiter. Iron deficiency causes anemia. Zinc deficiency causes growth retardation, and undernutrition of vitamins include thiamine deficiency, cause beriberi disease, and niacin deficiency cause plagira, and vitamin C deficiencies cause scurvy, and vitamin D deficiency causes rickets. Burden of disease in Pakistan. The double burden of malnutrition is becoming increasingly apparent in the country. Almost 1 in 3 children are underweight, 28.9%, alongside a high prevalence of overweight, 9.5%, in the same age group. Dimensions of the problems are not enough known. On a global scale, the 5 principal nutritional deficiency diseases that are being accorded the highest priority actions are kwashiorkor, marasmus, xerophthalmia, nutritional anemia, and endemic goiter. Macronutrition, protein calorie malnutrition, PCM, that includes kwashiorkor and marasmus. And micronutrients malnutrition include vitamin A deficiency, VAD, iron deficiency anemia, IDA, iodine deficiency disorder, IDD. These 5 disease states represents tip of the iceberg, and much larger population is affected by hidden burden. Etiology of malnutrition. First is primary malnutrition, and second is secondary malnutrition. Primary malnutrition includes because of ignorant and erroneous food habits or scarcity of food supply, low income, low purchasing power, and overpopulation. Secondary malnutrition causes are infections, particularly respiratory infections, diarrhea, and intestinal malabsorption, congenital defects, metabolic disorder, insulin resistance, and diabetes. Concept of food gaps. Protein energy malnutrition is primarily due to inadequate intake of the food gap, both in quantity and quality. Infections, most notably respiratory infections, diarrhea, measles, intestinal worms, which increase requirement for calories, proteins, and other nutrients while decreasing their absorption and utilization. It is vicious cycle: infection contributing to malnutrition and malnutrition contributing to infection, both acting synergistically. This is the cycle of malnutrition and infection. That disease incidence, duration, and severity. Disease lead to appetite loss, nutritional loss, malabsorption, altered metabolism, that lead to inadequate dietary intake, that again lead to weight loss, uh, growth filtration, immunity lowered, and mucosal damage, that again lead to disease. And this is cycle. Web of causation. There are numerous contributory factors in the web of causation of malnutrition. Number one, poor environmental condition, large family size, poor maternal health, failure of lactation, premature termination and breastfeeding, adverse cultural practices relating to child rearing and weaning. Malnutrition is perpetuating a child's nutritional status at any point of the time depends upon his or her past nutritional history, which may particularly account for the present status. To some extent, this nutritional history is linked to the mother's health and nutritional status, which in turn has been influenced by her living condition, nutritional history during her own childhood. Influence of each generation's nutritional status on the following generation. Neonatal and nutritional status of the pregnant woman, that influence the nutritional status of lactating women, and that influence the neonatal and infant nutritional status. Girls' nutritional status at the puberty, and nutritional status of the woman of the childbearing age. And then this is the cycle. Measurement of the undernutrition. In children, undernutrition is the synonymous with growth failure. To get a measurement of malnutrition in a population, young children are compared with a reference population known to have grown well. Use of measurements of dimensions of human body such as weight and height is called anthropometry. Three common used anthropometric indices are weight for age, WFA, length or height for age, HFA, weight for length or height. The anthropometric indices correspond to the three states of malnutrition: weight for length or height, that represent wasting; height for age, that used for stunting; weight for age, used for underweights. Each of the nutrition indicators is expressed in the standard deviation units, Z scores, from the median of the reference population, based on which undernutrition may be classified as a mild, moderate, and severe. These are different classifications: Coombs classification, Waterloo, WHO wasting, WHO stunting, Ganawati, and Cole. In Coombs classification, weight below percent median, weight for age, that is then next is grading, mild grade 1, that includes 75 to 90% weight for age, and moderate grade 2, 60 to 74% weight for age, severe grade 3, less than 60% weight for age. And in the Waterloo classification, Z score ST below median, weight for height, mild, moderate, and median. Mild include 80 to 90% weight for height, moderate include 70 to 80% weight for height, and severe include less than 70% weight for height, and the other scale. Underweight. A child whose weight for age, WFA, Z score is at least 2 standard deviation, 2 SD, below the median in the World Health Organization child growth standard. Underweight, it is composite measure of the stunting and wasting, and is recommended as an indicator to assess the changes in the magnitude of malnutrition over time. It can result from either chronic or acute malnutrition or both. It is often used as a basic indicator of the status of population health. Evidence suggests that mortality risk of the children who are even mildly underweight is increased. Stunting. A child whose height for age Z score is at least 2 standard deviations below the median in the World Health Organization child growth standards. Wasting. A child whose weight for height Z score is at least 2 standard deviation below the median in the World Health Organization child growth standards. Wasting represent a recent failure to receive adequate nutrition and may be affected by the recent episode of the diarrhea. It indicates current malnutrition resulting from the failure to gain weight or actual weight loss. Wasting in individual children and the population can change rapidly and shows marked seasonal patterns associated with changing food availability or disease prevalence to which it is very sensitive. Severe acute malnutrition. A child whose weight for height Z score is 3 standard deviation below the median in the World Health Organization child growth standards or mid upper arm circumference less than 115 millimeter or has presence of nutritional edema. Severe acute malnutrition, it can be an indirect cause of the child death by increasing the case fatality rate in the children suffering from common illnesses such as diarrhea and pneumonia. Children who are severely wasted are 9 times more likely to die than the well-nourished child. Kwashiorkor, a form of the protein energy malnutrition when the main cause is inadequate protein intake and low concentration of essential amino acids. It is severe form of undernutrition which develop in the individual on diet with low protein energy ratio. The main symptoms include edema, wasting, liver enlargement, hypoalbuminemia, steatosis, depigmentation of the skin and hair. Marasmus, a form of protein energy malnutrition when the main cause is inadequate intake of both protein and energy. It is form of severe cachexia with weight loss as a result of wasting in infancy and childhood. Main symptoms include severe wasting with little or no edema, minimal subcutaneous fat, severe muscle wasting, and non-normal serum albumin level. This picture showing the difference between the Kwashiorkor and marasmus. In Kwashiorkor, it developed in the children whose diet are deficient of protein, and in marasmus, it is due to deficiency of protein and calories. Kwashiorkor, it occurs in the children between the 6 months and 3 years of age, and marasmus, it is common in the infants under 1 year of age. In the Kwashiorkor, subcutaneous fat is preserved, and in the marasmus, subcutaneous fat is not preserved. In Kwashiorkor, edema is present, and edema is absent in marasmus. And large fatty liver in the Kwashiorkor, no fatty liver in the marasmus. Ribs are very prominent, and ribs are not very prominent in the Kwashiorkor. Ribs become more prominent in the marasmus. Kwashiorkor child are lethargic, while the marasmus child are alert and irritable. Muscle wasting mild or absent in the Kwashiorkor, severe muscle wasting in the marasmus. Poor appetite in the Kwashiorkor. They have enough appetite or voracious feeder. The person suffering from the Kwashiorkor needs adequate amount of proteins. The person suffering from the marasmus needs adequate amount of proteins, fats, and carbohydrates. Preventive measures. First is health promotion. Measures directed to pregnant and lactating women include education, distribution of the food supplements. Second, include promotion of the breastfeeding, development of the low-cost weaning foods. The child should be made to eat more food at the frequent intervals, and measures to improve family diet. Health promotion include nutritional education, promotion of the correct feeding practices, home economics, family planning and spacing of the birth, and healthy family environment. Second is specific protection. The child's diet must contain protein and energy-rich food. Milk, egg, fresh fruit should be given if possible. Second, immunization of the children as per EPI, and the growth monitoring on the growth chart, especially of the all children under 3 years of age, and the food fortification. C is early diagnosis and the treatment. It includes periodic surveillance, early diagnosis of any lag in growth, early diagnosis and treatment of infections and diarrhea, development of the programs for early rehydration of children with diarrhea, development of supplementary feeding programs during epidemics, and uh, deworming of heavily infested children. D is rehabilitation, nutritional rehabilitation uh, services via outpatient therapeutic feeding, ready-to-use supplementary food, thus, and the ready-to-use therapeutic food, RUSUP and RUTUF, and other is hospital treatment. If medical complication arises, and follow-up care. Management of severe acute malnutrition child, SAM. The body of the malnourished child may have compensated for the micronutrients deficiency with lower metabolic and growth rate. Spontaneous refeeding may mask these deficiencies. Nutritional rehabilitation should be initiated and advanced slowly to minimize these complications. Follow WHO guidelines for the children, treat and prevent hypoglycemia in them, and treat and prevent hypothermia, prevent dehydration, correct electrolyte imbalance. 5 is treat, prevent infection, correct micronutrient deficiency, initiate refeeding, facilitate catch-up growth, provide sensory stimulation and emotional support, and prepare for follow-up after recovery. These are two phases of stabilization and rehabilitations. That different hypoglycemia, hypothermia, that include how many days, hypoglycemia, hypothermia, dehydration can be stabilized in 1 to 2 days, and electrolyte imbalance that can be on two phases stabilization and rehabilitation. It can take 2 to 6 weeks, and infections can be treated 3 to 7 days, and all other factors. Management of the SAM child. When there are no medical complications, a severely malnourished child who has an appetite is given a standard dose of RUTUF adjusted to weight. Guided by appetite, the child consumes the food at home directly from the packages with supervision from the caregiver at any time of the day. A child being treated for severe acute malnutrition generally requires a total of 10 to 15 kg of RUTUF consumed over a period of 6 to 8 weeks. Refeeding syndrome. If aggressive carbohydrates are given during the course of refeeding, there is increased insulin level resulting in the shifting of potassium, phosphate, and magnesium into the cell. The severe hypophosphatemia during refeeding produces weakness, rhabdomyolysis, neutrophil dysfunction, cardiorespiratory failure, seizure, at a level of consciousness, even sudden death. Assessment of nutritional status. The nutritional status of an individual is often influenced by the adequacy of the food intake, both in terms of quantity and quality, and also by physical health of the individual. The nutritional status of community is the sum of the nutritional status of individual who form the community. The purpose of the nutritional assessment is to develop a healthcare program that meets the need defined by the assessment, including evaluation of the effectiveness of such programs. A proper nutritional evaluation demands a multi-angled approach covering all the different stages in the natural history of nutritional disease. Natural history of nutritional disease includes pre-pathogenic period and period of pathogenesis. Nutritional surveillance, keeping watch over the nutrition in order to make decisions that will lead to the improvement in the nutritional population. 3 district objects: aid long-term planning in the health and development, provide input for the program management and evaluation, and give timely warning and intervention to prevent short-term food consumption crisis. Growth monitoring and nutritional surveillance factors include strategy, growth monitoring, and growth surveillance. Growth monitoring include preservation of the normal growth, and nutritional surveillance include detection of the undernutrition, and approach include education and motivational in the growth monitoring, and diagnostic interventions in the nutritional surveillance, and many other factors. and also um, maintaining the good nutrition in the growth monitoring and detect malnutrition in the growth surveillance. Indicators for the nutritional surveillance. These are the indicators: maternal nutrition, birth weight, infant and the preschool children. Indicators are proportion being breastfed and proportion on the weaning food by age in the months, mortality rate in the children ages 1 to 3 to 4 years, which emphasize on the 2-year-old. And if the age is known, height for age and weight for age. If age is unknown, weight for height and arm circumference, clinical signs and syndrome. School child nutrition, height for age, and the indicators are height for age and weight for height at the 7 years or school admission, clinical signs. The assessment methods include the following: clinical examination, anthropometry, biological evaluation, functional assessment, assessment of the dietary intake, vital health statistics, and ecological studies. Now coming to the recent updates. In the UNICEF key facts about Pakistan, nearly 10 million Pakistani children suffer from stunting. 8 out of 10 children in Pakistan do not eat right type and quantity of food. Pregnant women need a diverse diet rich in the vitamins, minerals, though this is rarely the case in the Pakistan. And the challenges, the situation is quite dire in the Pakistan, with stunting and wasting heavily prevalent in the country. Stunting does not only mean that a child is not having enough to eat, it is about quantity and quality of the diet besides other factors. Inadequate nutrition among mothers during pregnancy is one of the main reasons for malnutrition among the children, leading to stunting. Only 38% of the children are exclusively breastfed for the 6 months of their lives. As a result, more than half of the children under 5 years of age are deficient in vitamin A, 40% are deficient in both zinc and vitamin D, and nearly 62% are anemic. Stunting and wasting critically, the diets of Pakistan children require substantially more diversity, in most cases lack sufficient calories. A focus on the quality of diet is essential to prevent stunting, wasting, and other form of malnutrition. Breastfeeding is a critical nutritional intervention for improving both the dietary quality and quantity of the children. Breast milk alone meets all the nutritional needs, in fact, of infants up to 6 months of the age. In addition, providing immunological and psychological benefits, a mother's diet affects the health and well-being of the both mother and the children. UNICEF supporting the scaling up to nutritional specific intervention that focus on the micronutrient supplements, fortification, diverse diet for the pregnant women and children under 2, along with enhanced breastfeeding practices. In a WHO nutrition and food safety for Pakistan is a progress in child malnutrition is not been encouraging. The latest national nutritional survey conducted in 2011 has shown global acute malnutrition rate of 15.1, higher than the 13% figure of the previous 2001. This disaggregate wasting rate in the urban and the rural population 12.6% and 16.1% respectively. More than 30% of children are underweight, 44% are stunted, 49% women are moderately anemic, and more than half of the children under the age of the 5 are anemic, and 39% of the children are zinc deficient. And National Parliament of the Pakistan has the first ever global on the SDGs, the nutritional February 2016, whereby malnutrition situation in the Pakistan was declared as an emergency. There is an article, Prevalence Trends and Socio-economic Determinants of Coexisting Form of Malnutrition Amongst Children under the 5 years of age in Pakistan. In Pakistan, coexisting form of malnutrition, CFM, is the major public health problem. 1/3 of the children ages under 5 years old are malnourished. Sindh and the Balochistan showed a persistent higher prevalence of the CFM compared with the other region of Pakistan. A significant association of the socio-economic status with various forms of the CFM was found, except for the coexistence of underweight with wasting. Improving the socio-economic status may help to alleviate the various form of the CFM. Integrating nutritional sensitive and nutritional specific interventions are effective way to evaluate alleviate the malnutrition, including CFM, and thus active engagement of the multiple stakeholder, not only from the health sector but also from education, food, agriculture, economic, and planning and development is essential for combating issue related to malnutrition. Now coming to the MCQ session, MCQ number 1 is a researcher want to assess the nutritional status of representative sample of the children in a village A. Whether it is good or bad, is better or worse than that of the village B and C, and whether it is improving or deteriorating over time. The most appropriate means to carry out such an assessment in the community is option A, anthropometry, option B, clinical examination, option C, functional statistics, option D, growth monitoring, option E, nutritional surveillance. Answer is nutritional surveillance. MCQ number 2 is a lady health visitor provide oral rehydration therapy to the child with some dehydration as a protocol for secondary level of prevention. This intervention must have been given as a part of option A, biological assessment, option B, clinical examination, option C, functional statistics, option D, growth monitoring, and option E, nutritional surveillance. Answer is D, growth monitoring. A 45-year-old man presents with numbness and tingling in his hands and feet, difficulty walking, and a swollen, beefy red tongue. His diet primarily consists of polished rice and little else. What is the most likely nutrient deficiency causing this symptom? Option A, vitamin B12 deficiency. Option B, thiamine deficiency. Option C, niacin deficiency. Option D, folate deficiency. Option E, vitamin E deficiency. Answer is thiamine deficiency. A researcher come to know that the most common formulation of the root of consists of the 4 food ingredients: milk powder, peanut paste, vegetable oil, and sugar, and multiple micronutrients to provide complete complement of vitamins and minerals. The choice of the food ingredients may be adjusted depending upon the local availability, cost, and accessibility. But the nutritional composition must include at least option A, 1 to 12% of the total energy from carbohydrates, and 10 to 12% of total energy from proteins, 10 to 12% of total energy from lipids, 10 to 12% total energy from vitamins, and 10 to 12% total energy from minerals. Answer is B. Yes. A 5-year-old girl is brought to the clinical with the complaint of the irritability, swollen legs, and swollen belly. Her diet mainly consists of maize. On examination, she has signs of edema, hepatomegaly, and flaky paint dermatitis. What is the most likely diagnosis? Option A, marasmus, option B, rickets, option C, Legra, option D, kwashiorkor, and option E, beriberi. Answer is D. 6 MCQs. A young anxious mother visits the primary health care facility and expresses concern about the lack of the age-appropriate growth for her infants, who is currently at the 6th month of the age. The most appropriate means to detect early onset growth faltering in his child would be option A, anthropometry, option B, clinical examination, option C, functional statistics, option D, growth monitoring, option E, nutritional surveillance. Answer D, growth monitoring. Family health practitioner prescribes ready-to-use therapeutic food for an acutely malnourished child. In order to demonstrate the maximum effect, the quantity and quality of root of protein should be able to support the average weight gain per kilogram of the body weight per day. For optimal recovery from the severe acute malnutrition is option E, 2.5 gram, option B is 5 gram, option C, 7.5 gram, option D, 10 gram, and option E, 12.5 gram. B. Answer is D, 10 grams. For an experimental study, a researcher wishes to propose an alternative root formulation that employs a combination of the cereals, legumes, grains, and different sources of the animal's proteins with a reduced amount of the dairy protein or no dairy at all. According to the UNICEF categorization, the alternative root formulation can be grouped as A, option A, alteration, option B, combination, option C, innovation, option D, renovation, and option E, novel. A. It is option C. innovation. MCQ number 9 is a 2-year-old boy present to clinic with the history of the poor growth, chronic diarrhea. His mother reports that he has a poor appetite and frequently refuses to eat. On examination, child appear underweight with a distended abdomen and sign of muscle wasting. What is the most likely diagnosis? Option A, Kwashiorkor. Option B, marasmus. Option C, celiac disease. Option D, iron deficiency anemia. Option E is vitamin D deficiency. Answer
B.
is option B, marasmus. A 30-year-old man presents with the night blindness and frequent infection. On physical examination, he has dry scaly skin, without spots on the conjunctiva. What nutritional deficiency is most likely responsible for this symptom? Option A, vitamin A deficiency. Option B, vitamin D deficiency. Option C, vitamin C deficiency. Option D, zinc deficiency. Option E, iron deficiency.
A.
Yes, A is the answer, vitamin A deficiency. This is the key of MCQ. These are references of my presentation. This is YouTube link where all presentations are uploaded. Kindly like and subscribe this channel. And thank you so much.
Okay, thank you very much, Dr. Marina. Please stop recording. And there is a very important presentation. Please stop recording.
Yes, ma'am.